Hi everyone. I'm gonna just go live on Instagram here. Okay, give me 1 second and then we will get started. Hi everyone, we are going live in just 1 second. Okay, here we go. All right, welcome everyone. We are uh, we're on Talk Shop Live, and we are also on Instagram and Facebook and YouTube. And I am so excited to see everyone here. And we're going to do a live Q&A for anyone who is new here. I am Eleonora Teplinsky. I'm a board certified medical oncologist. I'm also the author of Beyond the Pink. I'm going to show it here if you're on Instagram to see it. It is this beautiful book that comes, oh, I can't get in the frame. Here we go. Navigating Life, Health, and Breast Cancer. It comes out on September 29th, 2026. And it really is a patient-centered guide for previvors, survivors, thrivers, and it goes into anyone who is newly diagnosed, who's been living with disease, diagnosis, treatment, and what comes after, and really all of the things that we don't talk about as much as we should. Sexual health, mental health, bone health, you name it, it's in the book. And so I'm going to answer all your questions. Hi, everyone who is here. And then throughout the live, if you're watching on Talk Shop Live, you can actually purchase a signed copy, or you can comment shop in the comments or in the DMs, and it will send you a link to pre-order a signed copy. If you're having trouble, just reach out to me. So we're going to just kind of go through some of the questions. And thank you everyone who is joining. Hello, and tell me where you're joining from. We have people from San Diego, kind of throughout the country. So we'll start with Chandra, who's asking where did I study medicine and how did I decide to specialize in oncology? So I went to the College of New Jersey for undergrad, and then I went to medical school at Tufts Medical Center in Boston, and then I stayed there for my internal medicine residency. So you do 3 years of residency, and then I did 3 years of hematology oncology fellowship at NYU in New York City. And I went into oncology specifically. I've always been interested in medicine. But when I was 16 years old, my grandmother was diagnosed with ovarian cancer. And this was a time where there was nothing. I mean, there was chemotherapy. We had no targeted therapies. There wasn't even really genetic testing. And that experience and kind of seeing her treatment and what she went through really inspired me to focus on women's health. And so that's why I treat both breast and gynecologic cancer, and it's something that I am just so privileged and honored to be able to do every day. So Gina asks how the book is sectioned out. So the book and has about 380 pages. That includes references. There's about 400 references in the book. So anything you read, you'll be able to reference, and you'll be able to show that to your medical team. So if you want, guidance about supporting vaginal estrogen use, there are references that you can link to. Now, how it's sectioned out, it starts off by talking about breast cancer risk, breast health screening, mammograms, MRIs, biopsies, and then it goes into diagnosis, kind of what happens next, what you should be doing, treatment, metastatic breast cancer, a chapter on equity, and how we can improve equity in breast cancer care. We have a chapter on previvors and genetic testing, fertility, pregnancy after breast cancer. Then we dive into menopause, and we dive into sexual health and bone health, cardiovascular health, musculoskeletal health, mental health, relationships, parenting, talking to children, and ends with, and it was really important for me to end the chapter with lifestyle and what we can do to live our healthiest life. And it's kind of addressed throughout the book, but it really focuses on exercise and movement and diet and nutrition and all of the things, sleep, all of the things that are so foundational. And so that's how the book is sectioned out. And I wrote it specifically. It's got stories from previvors, survivors, and thrivers throughout each chapter. And I wrote it that you can pick up each chapter and you can read the section that speaks to you in the moment. So if you want to read about your heart, you can read that chapter on its own. If you are not ready to read about recurrence risk or metastatic disease, you can skip that chapter. So everything is designed to be kind of read either sequentially or on its own. So let's move on to some of these questions. So Jack Pigula says she has a double mastectomy scheduled for Friday. I wish you lots of luck. She's a hormone receptor positive, HER2 negative breast cancer, nervous about what's next. So I can't provide medical advice, but how we think about it, we start kind of, and I frame this in the book in more detail, but basically what we're trying to figure out is there are several buckets of treatment as we think about with breast cancer. So we have to think about surgery, we have to think about radiation, and then systemic therapy. And systemic therapy can include chemotherapy, targeted therapy, endocrine therapy, immunotherapy, anti-HER2 therapy. It's very broad depending on what your type and stage of breast cancer is. And so for here, we're going to have to consider definitely endocrine therapy because it's hormone receptor positive. Will we need other treatments like chemotherapy? That will depend on, again, molecular testing and stage. Will we need CDK4/6 inhibitors? That will again depend on all those factors. So hard to say here, but I wish you luck and I hope it goes smoothly and you have a beautiful recovery. Angela asks, so she has a stage 1A hormone receptor positive breast cancer. She's 43 at diagnosis, 45 now. She asks the question of, should I consider having my fallopian tubes removed? And so this is something that's been in the news recently, in this concept of opportunistic salpingectomy, meaning we now know, we've known for a while, but it's really getting more attention, that fallopian ovarian cancer actually starts, a lot of ovarian cancer actually starts in the fallopian tubes. So there's been a big push. If you remove the fallopian tubes, you keep the ovaries, you have about a 40 to 80%, depending on which study you look at, lower risk of ovarian cancer. And by keeping the ovaries, you don't go into menopause, it doesn't impact ovarian reserve, and it's really minimal addition to any operative time or complications. And so this concept of opportunistic salpingectomy for women of average risk of ovarian cancer is if you're having a abdominal or pelvic surgery for something else, if you're having a hysterectomy for fibroids, or maybe even a hernia surgery, can you ask them to remove your fallopian tubes at the same time when you're done having children, to reduce ovarian cancer risk? And I think this is something that's so important and not talked about nearly as much as it could be. Two caveats. One, you need to know your ovarian cancer risk. So genetic testing, do you have a family history, right? Because this is currently only for average risk individuals, number one. Number two, the other thing that's really, really important is, we're not at this point recommending it for people to just have their fallopian tubes removed if they're not having any other surgery, but that could be something you discuss with your team. So I hope that answers that question. We've got people here from Alabama, Detroit, New York. I love seeing Austin, even UK, Texas, so Paris. I love seeing people from all over the world joining. This is a great question from Jason. How can we best support family and friends going through the cancer journey? I love this question. And it's one that I hear from my patients all the time. And so a lot of what I share it's coming from what people have told me. And I think the best advice, but feel free to put in also what you guys who are listening would add, because I think we can learn from each other. But my advice always is don't ghost, show up. So much support happens when someone's newly diagnosed. So if someone's going through chemo and people are helping them, they're bringing them food and they're giving rides and all of these things. But then chemo is done, and a lot of times the support gets quieter, or someone's recovered from surgery and the support gets quieter. And yet, this is often the time when people need support the most, because they're still suffering from a lot of side effects. A lot of the treatments that we give last for a long time. And they're 5 to 10 years of therapy, and there's a lot of residual side effects, a lot of new side effects. And yet, at the same time, where people have these side effects, they also have to go back to work. They have to go back to their lives and parenting and relationships and all these things, and yet they're suffering. So they have less support. They now have more responsibilities, and so it's really tough. So I think show up when active treatment is done. Check in and say, and offer tangible support. This is the best advice I give, meaning don't say, hey, I would love to help you. What can I do? Or let me know if you need help. And I think this is an instinct. We're all coming from a good place. I mean, I will admit I've done it also, but instead say, what's your favorite restaurant? I'd love to have dinner delivered. What's one or two things on the menu that you like? Or can you pick a day that I can bring you dinner, right? So really tangible support. And then also restaurant gift cards, I think always go a long way rather than maybe bringing a dish that someone may not want to eat or not have the taste buds for and things like that. Okay. Oh, this question from JSD 1124. So she's on Lupron and Anastrozole and is going to start Kisqali, which is a CDK4/6 inhibitor. She's worried about her bones, which are good right now. What are all the things that I can proactively do to prevent bone loss? Great. So first is getting a baseline bone density, which it sounds like you have had. Everyone should be getting a baseline bone density. I will say, I see this so many people not having a bone density. Ask if you have not been offered one, say, I would like to get a baseline bone density. That is going to help us understand where we start from, and that where we start from can correlate to where we kind of go. If someone starts with a normal bone density, they're much less likely to develop significant osteoporosis, although it can happen. If someone starts with osteopenia, they're a little bit more likely to develop worsening bone density. So the starting point matters. So we get that baseline bone density. The best thing is calcium, vitamin D, and movement and strength training, improving body composition. Actually, I have a Substack coming out tonight or tomorrow morning about a study that looks at how body fat percentage can worsen fracture development or progression. And so knowing body composition, and the best way to improve our body composition is with lifting and strength training. If we when we lift weights, that creates tiny little tears in our muscle. And as the muscle repairs itself, it hypertrophies and gets bigger. So it strengthens the muscle, and that puts more force on bone, which strengthens the bone. And then the bone releases bone proteins, which strengthen muscle. And so this really good positive feedback loop. And so many people, my patients will ask me in clinic, how do I lift? What do I lift? Like, what's the weight I should be doing? And I talk about this in the book, but we talk about this concept of progressive overload, where, if you're doing, let's say, 3 sets of 8, that third set, that weight should feel really heavy. If you can kind of do bicep curls the whole time I'm talking here, probably not going to strengthen that muscle as much. So if you get to a point where that third set of 8 feels heavy, you're right at the right place. If that third set of 8 feels really light, so you've done 24 reps now and you're like, I could keep going all day, we want to bump up the weight. And that's a great place to start. I really like Living Beyond Breast Cancer has beautiful, like great intro web videos about weightlifting on their YouTube. And then also Live Strong Online has great resources. I personally like Peloton for myself, and I recommend it to a lot of people because they have great programs that you can do, and you don't need any Peloton like bikes or treadmills to do those. I'm going to try to move through some of these questions. I'm loving, there's so many fantastic questions here. See here. So what is the number one, and I'm going to try to do as many as I can. Evelyn asks, what is the number one cause of this type of cancer other than genetics? And so, this is a common misconception because only about 5 to 10% of breast cancers are genetically linked. Most patients with breast cancer do not have a strong family history of breast cancer. And so, as we're seeing younger and younger cancer too, there's been a lot of questions asked about why is younger breast cancer on the rise, and why is younger cancer on the rise in general. But I think, we think about a couple of things. So for breast cancer, reproductive factors, girls are getting their periods earlier than they used to, which increases risk. People are having children later in life or not having children at all, which also increases risk. It's not all of it though. Lifestyle makes a difference. Alcohol can increase breast cancer risk. But the question that a lot of us have, and I really have too, is, what is the role of environmental factors? Things that we're exposed to every day in our environment. How is that increasing risk? And I think there's a lot of ongoing research that hopefully will answer this question, but currently we have a lot of unknowns. So I like to think about what are things we can each do, and that it really comes down to those foundational lifestyle things. Keisha is asking, can you elaborate on CDK4/6? And is it now the standard of care for women who are high risk? And we have Verzenio and Kisqali. And how do we pick between each one? So this is a group of medications. And again, you're going to find all of this in the book. So I'm going to keep plugging it because it's my baby and my project. And I would love for all of you to pre-order it. But you're going to come and shop, or if you're on Talk Shop Live, you can kind of just click and purchase it through the app. So I go into that in the book. But CDK4/6 inhibitors are a class of medications that we use both in metastatic and early stage breast cancer. In early stage breast cancer, they are combined with endocrine therapy to further reduce the risk of recurrence. And we have two for early stage. We have Kisqali and Verzenio. And they both are very beneficial. Verzenio is taken for 2 years, Kisqali is taken for 3 years, but they each have slightly different requirements. So some people will, and Verzenio is a little bit more narrow in its eligibility based on how it was studied. So some people will be eligible for both, and some will only be eligible for Kisqali. And they have different side effects. So the choices kind of depend on also on side effects. So Kisqali is more likely to cause liver problems. Verzenio is more likely to cause diarrhea and GI toxicity. One is 2 years, one is 3 years. So a lot of these things we think about based on each individual's eligibility, side effects, risk of recurrence, and we make that decision. I have patients on both, and we can also swap from one to another if we need to. Laura says, Dr. Teplinsky, for those who was just hearing about Beyond the Pink, what made you feel that this was the right time to write this book? And then there's a second question about, goes beyond what's happening in the doctor's office. What are some of the biggest questions or challenges that patients are dealing with? And I think the reason and the goal of my book is to focus on the things, the conversations we're not really having. And that you'll see, there's information on treatment, but treatment is changing so rapidly. Even in the course of me writing the book, there were about 5 new FDA approvals for treatment. So I constantly was rewriting. And so I made the treatment section intentionally a little broader because the choice of what treatment you get is so individualized and nuanced with your team. And that I think we really, are addressing in the clinic. What we don't always have time to address in the clinic, and I don't always have time either, is topics that are so important to living after a breast cancer diagnosis, whether you're living with metastatic disease or early stage breast cancer. Again, these topics of sexual health and menopause, we're going to answer the menopause question in a second. Your heart, your bones, your brains, your muscle, right? If I had 6 hours to spend with somebody, these are the topics that I'd want to talk about. So I really focus on where we don't always have enough guidance, but it's all driven by studies, by evidence, and where there isn't evidence, I'm very clear to say that there is or isn't, what are the trials that are ongoing. Kira asks, how do you recommend patients start conversations with their doctors about things that they may feel embarrassed or uncomfortable discussing? And this is so common. And I see this often, especially with topics of sexual health, where people are nervous about bringing it up and they're not sure. One of the best ways is send a message on the portal. So say I'm coming in for an appointment tomorrow or next week, and I'd like to talk about this. So you're opening that door, and you've kind of, the doctor or the healthcare team knows what you want to talk about. And you can, if you're uncomfortable even bringing it up, you say, I sent a message on the portal. Can you take a look at that? If there is somebody on your team, maybe your nurse or a nurse practitioner or somebody else who you may feel a little bit more comfortable talking with, ask them, and they can open that conversation. And then lastly, maybe bring someone with you who isn't as, maybe, who can advocate for you if you don't feel comfortable bringing it up yourself. Somebody who comes with you can say, hey, let's talk about this topic. There's a great question about, are there any ongoing trials for hormone replacement therapy for hormone receptor positive survivors? Feels like we have no options to prevent the long-term effects of estrogen deprivation. So two parts to this question. My In the book, I talk very little about hormones, and that was very intentional because there are so many incredible books written by amazing menopause specialists about hormones, and I those books, and the Menopause Society is great resources, and so those books are out there. What I really wanted to focus it on is all of the non-hormonal options that we have, because so many patients tell me day in and day out, I feel left out of the menopause conversation. And hormones are just one part of the menopause conversation, so it was really important to me that we talk about all the other things. But I also talk about the data for hormones, and here is where the data is old. It's 20 plus years old. It doesn't reflect modern day hormone formulations. And so we know, I would say we know less than we know, like we just don't have a lot of data. And so I talk in the book, and this is how I do it in my practice, is I talk about what we know, what we don't know, and I make individual decisions with patients about, balancing risk of recurrence with what would be the benefit for hormones, what could be the risk for hormones. There's a big difference with somebody who has been diagnosed with a stage 3 hormone receptor positive breast cancer a year ago versus somebody who had a smaller cancer 15 years ago, or somebody who had a triple negative breast cancer. We should be thinking about all of these individually. The Meno ABC trial is a study that is proposed in the UK, and I'm hopeful it's going to start accruing soon. I know they had some holds due to financial constraints, and that study is really, hopefully, will be pivotal about looking at hormones in patients who've had breast cancer. I think we're also really becoming a little bit more open to testosterone therapy, and this is a conversation that's changing. So I think we're starting to think about using testosterone a little bit more. And what I'm doing in my practice, I'm keeping track of, patients and trying to at least get some data, pilot data, for myself in terms of who we're using it on and results and outcomes and all of that. But I'm hopeful this is an area that we need data, we need rapid data, and I think it's going to take all of us advocating together to push for that. Carrie says, you also cover fertility and menopause. For younger patients, especially, those issues can affect so many future plans. What do you wish more people understood about those conversations before starting? Number one, fertility preservation, that conversation has to happen before any cancer-directed therapy. We often think about fertility preservation before chemotherapy, and we don't always think about it in patients who don't need chemo but need tamoxifen or an aromatase inhibitor. And so I do think it's really important that we are talking about fertility preservation with everybody who is of childbearing age. And often, you know, and I was talking about this earlier on a podcast about how when someone's newly diagnosed, right, there's this pressure of like, I have to get started, I have to go on treatment, I don't have time to do fertility preservation. And we have data, we have studies showing that it is safe in the majority of cases to wait a few weeks to do fertility preservation, because what we don't want is to make such a sudden hasty decision because of that pressure, and then a few years later say, oh, I regret not doing it. And so I feel very strongly that we 100% need fertility preservation discussions more than once, for people, and referring people right away to fertility specialists. Anya says, she has a triple positive breast cancer. She's had treatment with chemotherapy and anti-HER2 therapy, surgery, radiation, and finished 11 rounds of Kadcyla, and her doctor's considering switching her to Enhertu for more treatments. And so this is obviously a very nuanced, specific question, but I will say that Enhertu is an antibody drug conjugate. It's been used for years for metastatic breast cancer, and now we're using it in earlier stage HER2 positive breast cancer. And so the decisions about switching or not, I can't answer that because there's a lot of nuanced factors that go into it, but I'll tell you about antibody drug conjugates. And they are kind of a very focused chemotherapy. People are calling them smart bomb chemotherapy, but the way that they work is They bind to a specific protein on the cancer cell, and then they inject chemo into that cell. So it's very targeted delivery of very potent chemotherapy. And in many cases, in metastatic breast cancer, they have been more effective than chemotherapy. And so they're really changing and revolutionizing how we are treating a lot of breast cancer. And HER2 is just one antibody drug conjugate. Kadcyla is another one. We also have Trodelvy, and we have Datroway, and many more are in development. Um, I love this message from the Kaya Mama about breast seeds. Don't be afraid of treatment. I think, um, and thank you for sharing that. There's a lot we can do. Treatment is hard, 100%, but there's a lot of support that we can provide. And there's so many incredible support groups and communities. And I think one of the power of social media is a lot of the communities that you can be part of and you can join. And in the book, I actually have a list of incredible organizations that you can check out too. And if you're new and not sure where to start and what organizations to support or be part of and be part of their community. Um, Nancy asks, for someone who's been diagnosed and is completely overwhelmed, where do you even begin? What do you hope readers take away from the book in those first days or weeks? I think is a great question. You are overwhelmed, and there is a lot of panic, and there's fear, and there's stress and anxiety. And I always think to take a breath. We have a little bit of time to kind of gather all of the information that we need. So when you're newly diagnosed, we don't immediately have all the data that we need to make a plan. I always call this we're in the information gathering phase, right? We're waiting for your pathology, you're waiting for your markers, any additional scans or imaging, any additional workup. And we need all of that molecular testing before we can make a treatment plan. And so I think starting by thinking about, what doctor do I need to see? And that's typically a breast surgeon. So getting that appointment. Um, don't be afraid to go for a second opinion, starting to make a list of questions that you're going to ask the surgeon, and then also bring someone with you to the appointment. Don't go alone. And if you don't have somebody that you can bring, ask if someone can be on FaceTime or on the phone with you. And if you don't have somebody, ask your surgeon's office. You should be connected to a navigator. If you are not, ask about being connected to a navigator that can help you move through that process. And often the navigator will come with you, or be someone in that surgeon's office who will sit with you and help you process that. I think that can be so helpful for people who may not have somebody to bring with them. Um, Zoe asks, you include stories from previvors, survivors, and thrivers. What did hearing from real people add to the book that medical information alone couldn't provide? Lived experience, hands down, lived experience. I have not been diagnosed myself with breast cancer, and I will say that so much of what I've learned is from listening to patients on my podcast, online, share their stories. And it was so important for me to make sure that the book was grounded in those stories of real people, real comments. And I think it will help. And in the book there are, most of them are, everyone's real. In some cases, names and identifying characteristics have been changed for privacy, but every story in there is real. There's quotes, and I think it makes the book stronger because that lived experience is something that I don't have, and I wanted to make sure that that was in there. Um, and then another question from Nancy about, what does being a good advocate for yourself look like when you're sitting in a doctor's office and may not even know what questions to ask? And I think it is so hard. I think it's easy for us to sit here and say you should advocate for yourself, but when you're in a doctor's office, when you're wearing that thin gown, it is hard. It is a very vulnerable time. And I've been in that situation as a patient where I thought I'm the best advocate for myself. And you know what? When you're in a doctor patient relationship, it can be really hard to advocate for yourself. And so I learned that, firsthand. But I will say is the best way is, if you're not sure what to ask, that's okay. Ask, you can ask the question of, is there something else that other people ask that maybe you can answer for me, or are there any other topics that we should be discussing? In the book, I do give you, in each chapter, I give you action steps and also some boxes with questions to ask your medical team. So that might be a good place to start. bring someone with you. You may not be sure what questions to ask, but maybe someone else will. And then also, when you leave the appointment, say to your medical team, if I have more questions when I go home and have time to think and read and research, what's the best way for me to get in touch with you? So that may be a patient portal message, that may be setting up another appointment, that may be coming in, to meet with the nurse, whatever that looks like, but have a plan so that when it's the next day and you've thought of five more questions, you know how to reach the team and what's the most effective way to reach the team. I'm going to try to get through some additional questions. We have about 10 minutes, 15 minutes left. Marjorie asks, what do you think the future is for breast cancer treatments? Do you think there will be more developments in the future? 100%. I think one of the developments that we are all really excited and looking forward to is hopefully going to be the approval of a SERD, a selective estrogen receptor degrader that works differently than our tamoxifen and aromatase inhibitors. This does not block estrogen, but it degrades the receptor. And the FDA is expected to vote on this by the end of November. The drug is called giredestrant, and there are other SERDs that are in development for early stage breast cancer. We already have them in the metastatic setting. And what this study with giredestrant showed was that it reduced the risk of recurrence by 30% compared to tamoxifen or an aromatase inhibitor. So that's quite significant. But also, there was better tolerability, better side effects. So I am very excited about that. I think that's a big one that we're all looking forward to. Lots of new drugs in development. There are breast cancer vaccine trials that are also in development that appear promising. So there's a lot happening. And I always say to my patients is that how we treat breast cancer today is not how we treated it 5 years ago, and it's not how we will treat it in 5 years. And I think that will continue to be true. Sophia says the word thriver really stood out to me. What does that word mean to you? And why is it important to recognize that everyone's experience with breast cancer can look different? Great question. Thriver, I wanted the book. I wanted everyone who reads the book to identify with whatever word they identify with, right? I didn't want to define that for anybody. Thriver is generally taken to mean somebody who is living with metastatic disease. But I think the beauty is that everyone can define the word and use words that resonate with them. Just like the terminology of, fighting, or that battle language of like losing the battle or winning the battle doesn't resonate with a lot of people, but it does resonate with others. And so I think it's important to use whatever language resonates with you and helps you feel good. The goal is never to have language that's triggering or scary or fearful as much as we possibly can. And everyone's experience with breast cancer is different. And one of the things that, this is not a question, but I'm going to mention it anyway, is there's a lot of guilt. There's survivor's guilt. And I will often see patients who are sitting in my office and they will be talking about a side effect and they say, I shouldn't complain about this. I feel guilty complaining about this because I didn't need to have chemo, or my chemo was milder than someone else's. Or people feel guilty because they had an earlier stage breast cancer and someone they know is struggling with a recurrence. So there's a lot of guilt, and two things can be true at the same time. You can feel grateful that maybe you didn't need chemotherapy, and at the same time can really be suffering with the side effects. So I really try to dissuade, kind of under talk about that survivor's guilt, and try to give people permission to feel whatever they want to feel. I think this is so important. Hi, Michelle from Boston. Ken says a lot of people probably think that once treatment ends, everything just goes back to normal. Is that really what the experience is like for most survivors? No, not at all. And we talked about this in the beginning of the video about how most things don't go back to normal. Cancer, no matter how early stage, less treatment, more treatment, it's a life-changing diagnosis. And so not only physically, but mentally, things are different. And I think it's important to recognize that, because so many people in your world will think, oh, you're done with treatment. Everything must be good, right? You're back to normal now. And you're definitely not. And so I think recognizing that, talking about that is so important. I'm going to go through a couple of more questions, and I love some of these comments here about support and survivorship, the support people have been getting. Amy shares how her husband, um, picked up where she left off in the household stuff, and I think that's great. Talking about, right, what you need. Very often, and Katie Couric just, I think it was Katie Couric just ran an article about how sometimes when someone doesn't look sick, right, we assume different things. And so very often in that survivorship period, when you're done with active treatment, or even when you're on active treatment, people feel, and then people look great. They don't look sick. And so then everyone thinks, oh, they're fine, right? They don't need me anymore. And so I think it's really important to verbalize those conversations. And in the book, I have an interview with a social worker who really navigates how to have those conversations, how to open that door to that conversation with your loved one when maybe they're resistant to talking about these things, or they think you're back to normal and you're anything but back to normal. So that's definitely in there as well. Bring food. Myra says, bring food, offer to take the kids for a few hours, give a gift card, all excellent suggestions. This is a good question. Is there any difference in effectiveness between Herceptin and Perjeta and the shot? So I'm assuming this means Herceptin and Perjeta IV versus subcutaneously, and no, both of those can be given. Some people prefer IV, some people prefer subcutaneous injections, but both can be administered. There's some questions about breast cancer index. And so breast cancer index is a tool that we can use, and I have a good subsec on this, kind of going over it in more detail, but it's a tool that we can use to determine if there is a benefit to being on endocrine therapy for more than 5 years. So that period between 5 and 10 years is extended endocrine therapy. And we can use this breast cancer index, which is a molecular test that we send on your tumor, to guide that discussion between 5 and 10 years. It's not for everybody, but we offer it whenever we can. And there actually have some expanded indications coming where for postmenopausal women, in certain situations, they may even be able to guide if there's a benefit to endocrine therapy at all, which I think is going to be really important. And in premenopausal women, they're going to guide on whether ovarian suppression is needed. So those expanded indications are coming. So something to keep in mind and ask your medical team about. Jazzy JB asks, is it recommended to get a bone density scan while on tamoxifen and Nerlynx, which is neratinib? We use that in HER2 positive breast cancer. Yes. Tamoxifen, if you're premenopausal, can lower your bone density, worsen it. If you're postmenopausal, it can improve your bone density, but I think it's always great to know where you've started, because if you're postmenopausal, you should be getting a bone density anyway. Let's see here. Okay. Low dose. Okay. Vaginal estrogen. I'm so glad we got this question from Victoria. Vaginal estrogen 100% can be used. We have data. We have so many studies showing that it is safe, that it does not get systemically absorbed, and if it does, it's teeny amounts, and that it doesn't reduce the risk of death from breast cancer. And then in most studies, except for one, which was deeply flawed, it does not increase the risk of recurrence. And yet, so many patients are met with resistance when asking their oncologist about vaginal estrogen. And so in the book, I'm going to hold it up here again. In the book, I have a whole section on vaginal estrogen therapy. It's lengthy, and my editors kind of said, we need room for other things. And I said, no, this has to stay in here. We have to talk about vaginal estrogen. And I copy and paste all of the guidelines, and there are links and references to all of the guidelines. So I'm hopeful you can, if you have been met with resistance, you can take that to your medical team and show them all of the references and all of the guidelines that do support the use of vaginal estrogen. Okay, let's take a look at a few more questions here. Are there things that people say with good intentions that maybe aren't as helpful as they think? Yes, I mean, we could do a whole video on this. I think some of them are, oh, at least you got the good cancer, or you're going to be fine. Actually, I saw this comment that someone made in a group recently of like, don't worry about recurrence, everything's fine. And so I think, again, those are coming from a good place. They're coming from a place of, um, they want you to be okay. They want you to feel reassured. But those comments generally don't sit well because there is no good cancer. And telling someone, like, don't stress, it's going to be fine, that does not take into account what they're feeling. And so even though I think these are important things, right? This is this concept of toxic positivity where someone tells you they're worried about something and you're like, well, don't worry, it's going to be fine. What are you worried about? Everything's great. And why are you stressed? And so I really like to refocus that conversation. And I do say that if you feel like you're in a comfortable place, you can say to somebody, this comment actually isn't helpful because of X, Y, and Z. And so maybe we can re educate a little bit. But I try to make those videos once in a while too. So maybe a caregiver will see it and or a friend will see it and go, oh, you know what? Maybe I will rephrase that question differently at the next time. Um, Okay, don't forget to, if you are on Facebook, if you are on Instagram, comment the word shop in the comments and you will receive a link in your DMs to order a signed copy. And then if you are on YouTube, make sure you click the link in the description to order. And if you're on Talk Shop Live, you can click, if you can purchase through the platform. We talked about SERDs versus anastrozole already. Okay, a couple of more questions here. A residual side effect. So Marianne says, a residual side effect I continue to have is neuropathy. Can you comment? This is so hard. We have made improvements in treatment of neuropathy with chemo by using compression and cooling, and I think that has been really helpful. There's a lot of patients with residual neuropathy who it was before the time they did cooling or compression, or they did those things and still have neuropathy. And the problem is that we just don't have a ton of great options. But a couple of things that can help, and I recognize it does not help everyone, include acupuncture, physical therapy, exercise. And this is a double-edged sword because if you have neuropathy and you have problems walking or you have gait issues or you have pain, exercise is certainly not something that is going to be it might not feel good. Um, and then there are some medications that can help. Duloxetine is a medication that is approved for chemotherapy-induced neuropathy. Sometimes we can use pregabalin, which is Lyrica. So there are some medications that we can use. They don't always help. Gabapentin is another one, but they don't always help. So I think that is hard. Dan says, speaking of evidence, with so much health misinformation online, how do you help patients separate fact from fear? There's so much misinformation online. I feel like every day someone sends me a video of like something wild. Like there was something recently that if you wear a bra, you have like a 90% chance of being diagnosed with breast cancer, which is just preposterous. And if you were like ridiculous things. And so there's no data to support that. There's in fact data showing that that the length of time you wear abroad does not correlate with breast cancer risk. And yet these things perpetuate a lot of misinformation about mammography and screening. And so I think if you see something that feels like, what is this? This doesn't make sense. Or if people are trying to say like, your doctor didn't tell you this, but I will, or, if they promise one thing that will cure breast cancer. If any of that sounds too good to be true, or they're trying to sell you something, those are big red flags. Look for the credentials for somebody who's sharing. Their credentials should be very easy to find. If they're not, maybe those credentials aren't what they seem, and follow the link to the studies. So if someone is claiming something, there should be a link to support it. If there is no data, if there's no study, if there's no evidence, then that may be their opinion, but opinions are not science. Opinions are opinions. And so those are the things that I look for. And I will say now we also have to deal with AI and AI misinformation and impersonators and deep fakes. And so it's becoming even harder to spot misinformation online. All right, we have room for about 2 or 3 more questions. Okay, GLP-1. Oh, great. I'm glad we asked that question. Is it safe for survivors? Yes. So we have a lot of data, and this is brand new. I mean, this has come out in the last like 2 to 3 months, really showing that, and we have known that GLP-1s, can be used in patients with breast cancer and other cancers. But a lot of the data that has come out recently is showing that not only can they be used, they may also reduce the risk of a new cancer or a recurrence. And what's interesting is that we don't know why that is. Is it because of the impact on weight, on metabolism, on inflammation, on insulin resistance, or is there something specific to the GLP-1 itself? And so there's a lot there that we don't quite know yet, but I think we can use it. And the challenge with those studies with the GLP-1s is that they were done in patients who qualify for being on a GLP-1, meaning um, they met the criteria based on diabetes or weight. And so there's been a lot of questions about people saying, well, what if I don't quite meet the requirements, but what about a lower dose, a microdose, or what if I go on it even if I don't meet the requirements? And we don't know that those benefits are going to be there, because these are all studies that are looking back. We don't yet have data, although clinical trials are ongoing, about prescribing a GLP-1 when someone's been diagnosed with breast cancer, and then following them to see how they do. Do they have a lower risk of recurrence? There are several ongoing clinical trials, so I'm hoping that that will answer that question soon for us. Why is testosterone relevant to breast cancer patients? Well, I think this is kind of a bigger question. I have a couple of videos on it, but as we get older, our testosterone levels decline. And currently, and this is where there's a lot of questions right now. Currently, the guidelines say that testosterone should be used for hypoactive sexual desire disorder and libido, and there actually isn't even a female FDA approved dose of testosterone. And so that's what the guidelines say. But we are seeing that women feel better in multiple different menopausal ways by being on testosterone. Um, they feel better with their strength, and they feel better cognitively. And again, this is all what people are reporting, and so we need more research here. But we have had some studies with testosterone and aromatase inhibitors. So I don't have time to go into all of that here, but I do have some videos on my social media that you can, where I do go into this in more detail. All right, okay. I'm going to answer this last question and then we will wrap up. And this is, what is my take on ctDNA after breast cancer in general? And I'm sorry I can't get to all the questions. There's so many amazing questions. Maybe we can do this again. So many great questions, but circulating tumor DNA. So what circulating tumor DNA is when all of our cells in the body shed DNA, and we can detect that. And so cancer cells in the body, as they die, they also can shed their DNA, and we can detect that in the blood. So that's what circulating tumor DNA is. And there has been a lot of interest in looking at circulating tumor DNA to see, can we predict a recurrence? Does having circulating tumor DNA in the blood impact prognosis? And so we have a lot of data telling us that yes, if you detect circulating tumor DNA in the bloodstream, there is going to be, in many cases, that will lead to a metastatic recurrence. And again, this data is being really kind of refined. But the challenge is we don't know what to do with that information. So if we do a blood test, let's say somebody has finished treatment and we do a blood test and their circulating tumor DNA is positive, that means that there are cancer cells circulating in the blood. So we do a scan. We would do a PET scan or a CAT scan or an MRI. And if we find a recurrence, okay, then we to treat that. But very often what might happen is that the scan will be negative. So you have circulating tumor cells, but you can't see them. We don't know where they are. And that becomes, and this is the Signatera test. There's also Guardant. There's a number of companies that look at circulating tumor DNA. And so that's our biggest challenge right now, is what do we do knowing that there are positive cells? We don't know what to treat with because we don't know what would be ideal, and we can't see it on the scan. And we don't know that treating, if you have circulating tumor DNA detected, but no findings on scans, treating with what? Will treating make a difference? Are you going to change the long-term outcome? Can you change that ctDNA from from positive to negative, or are you just putting someone in on harsher treatment earlier and it wouldn't have made a difference in long-term outcome? So there are like many studies ongoing that are answering this, and that they are intervening. So if someone has a ctDNA, they are starting them on this treatment or that treatment and seeing what happens to long-term outcomes. So I think that that is going to be really helpful, and I do think our conversations on this will change in the future. Um, Okay, and this can be rewatched. Yes. And I'm going to, before I answer this, yes, there's a great comment here about the key giveaway for misinformation, aside from going against all experts, is if they're selling something. 100%. If they are selling you something, they are asking you to pay thousands of dollars or not even any money for what they're selling that goes against all of the guidelines. Huge red flag. Underwire bras, deodorant, yes, all of those myths. You can wear an underwire bra, you can use deodorant. I do both of those things. I use regular deodorant because none of that has ever been shown to increase breast cancer risk. And lastly, yes, there is a role for endocrinology in breast cancer survivorship. I work with our endocrinologists all the time for bone health, for metabolic health, thyroid issues. Wonderful partners. So yes, this can be rewatched. This will live on definitely on the Talk Shop Live channel, which I'll share the link. It will live on Facebook for a certain period of time, on YouTube, and so you can come back to this. At pretty much every single thing that we talked about today is in the book. So as we wrap up here, if this has been helpful in any way, I would be so grateful if you pre-order the book. You get a signed book plate with it. The book's release on September 29th, 2026, and everything that we talked about is here with references, with evidence that you can use to talk to your medical team. So again, you're going to comment shop if you're on Facebook or Instagram in the comments, and you will get the DM sent to you. If you are on YouTube, click the link. And if you're on Talk Shop Live, you can purchase right within this platform. Thank you guys all so much for being here and for sticking it out with me and answering these questions. And again, I'm so grateful for this community, and just loved having all of you here with me. Thank you, and have a great rest of your night. And thank you for everyone who's pre-ordered already. Okay, I'm going to end show now, but again, you'll be able to rewatch.